USMLE Step 1 Questions and Answers Part 001 Dr. Jayachandran Thejis. Persistent buzzing one ear. Clinical examination normal. MRI shows intracranial lesion. Lesion is arising from which structure? Name of tumor? 8th CN. Acoustic neuroma. Anterior surface of brainstem. Map cranial nerves. Midbrain optic nerves on top. 3 and 4 CN at lower end, from medial to lateral. Pons trigeminal nerve from upper part. 6, 7, 8 CN from junction between pons and medulla, from medial to lateral. Medulla laterally, from above to below 9, 10, 11. Medially, 12. Acoustic neuroma. Which CN? 8. Which part of CN 8? Vestibular. From which cell? Schwann cell. CN 8 is typically seen in which part of cranium? CP angle. Symptoms? Cochlear nerve affection, more common. Ipsilateral sensorineural hearing loss and tinnitus. Vestibular nerve affection, less common. Vertigo, disequilibrium, nystagmus. Unilateral or bilateral? Usually unilateral. When bilateral? Men too. Symptoms of trigeminal N injury? Ipsilateral loss of facial sensation and corneal reflex, afferent limb affection. Paralysis of muscles of mastication. Features of abducens, CN6, injury. Horizontal diplopia and inability to abduct ipsilateral eye. Happens due to inability to contract lateral rectus. Features of facial nerve injury. Ipsilateral facial muscle paralysis upper and lower. Hyperacusis, lack of innervation to stapedius. Loss of corneal reflex, loss of efferent limb. Loss of taste in anterior 2/3 of tongue. Glossopharyngeal nerve, CN9, exits medulla from which sulcus? Postolivari sulcus. Features of CN9 injury? Loss of taste and sensation in posterior 1/3 of tongue. Absent gag reflex, loss of afferent limb. Features of CN10 injury? Dysphonia, laryngeal muscles. Impaired swallowing with inability to elevate soft palate, pharyngeal muscles. Loss of gag reflex, loss of efferent limb. From where does CN11, spinal accessory nerve, emerge? Lateral medulla and upper segment of cervical spinal cord. Features of injury to CN11? Weakness on head rotation away from side of lesion due to sternocleidomastoid paralysis. Ipsilateral shoulder droop, trapezius paralysis. Elderly man has sudden onset painless vision loss in one eye. There is cherry red spot in macula with surrounding retinal whitening. Diagnosis? Retinal artery occlusion. Path of embolus in retinal artery occlusion. Internal carotid artery, ophthalmic artery, retinal artery. Commonest cause of retinal artery occlusion. Internal carotid artery atherosclerosis leading to embolism. Which are the parts supplied by the retinal artery? Inner retina. Surface of optic nerve. Anterior cerebral artery supplies which part of the brain? Midline part of frontal and superior medial parietal lobes. Clinical feature of occlusion of anterior cerebral artery. Loss of strength and sensation in contralateral lower limb. Incontinence. Transcortical motor aphasia. An elderly person feels dizzy whenever he exerts. Doppler shows left vertebral artery retrograde or caudal flow. Which artery is occluded? Left subclavian. Subclavian steal syndrome commonly occurs due to stenosis of which artery? Subclavian artery, proximal to origin of vertebral artery. Causes of subclavian stenosis. Commonest cause atherosclerosis. Less common causes Takayasu arteritis. Complications of heart surgery like aortic coarctation repair. What is the steal in subclavian steal syndrome? Stealing of blood flow to the ipsilateral vertebral artery, away from brainstem. Usually are people with subclavian artery stenosis symptomatic? No, they are usually asymptomatic. Symptoms of subclavian steal syndrome? Arm ischemia, exercise-induced fatigue, pain and paresthesia. Vertebrobasilar insufficiency, dizziness, vertigo, syncope. What is physical examination finding in subclavian steal syndrome? How is diagnosis made in subclavian steal syndrome? Doppler. Which artery stenosis, other than right subclavian stenosis, can cause right-sided subclavian steal syndrome? Innominate, brachiocephalic, artery stenosis. What is coronary subclavian steal phenomenon? Subclavian stenosis in persons with IMA for CABG angina pectoris during upper extremity exercise. Person with viral upper respiratory infection 1 week back, now presents with dyspnea on exertion and chest tightness. ECG shows sinus tachycardia and low voltage QRS that varies in amplitude from beat to beat. Diagnosis: pericardial effusion after viral pericarditis. Commonest cause of acute pericarditis. Viral infections. Which are the commonest viruses responsible for viral pericarditis? Coxsackie A and B echovirus. Pain of pericarditis may be relieved in which posture? Leaning forward. What type of pericarditis occurs in viral pericarditis? Fibrinous or serofibrinous? What is the nature of chest pain in pericardial effusion? Chest tightness or fullness? What is the cause of exertional dyspnea in pericardial effusion? Decreased diastolic filling of ventricles leading to decreased stroke volume. Why is there tachycardia in pericardial effusion? To compensate for decreased diastolic filling. Auscultation finding in pericardial effusion. Decreased heart sounds. ECG finding in pericardial effusion. Low voltage QRS. Electrical alternans. Cause of electrical alternans in pericardial effusion. Swinging motion of heart leading to variation in QRS axis. Chest X-ray findings in pericardial effusion. Globular cardiomegaly. Clear lung fields because right-sided chambers are more compressed than left-sided chambers due to lower pressure. Why is pulmonary edema unlikely to occur in pericardial effusion? Because right-sided obstruction to blood flow is more than left-sided obstruction. How much fluid can accumulate in a slowly developing pericardial effusion? 1 to 2 liters. What is the location of pulmonary infiltrates in pulmonary edema? Peripheral more than peripheral. Give examples of pulmonary edema with normal cardiac silhouette and with cardiomegaly in chest X-ray. Acute MI, normal size of heart. Chronic heart failure, enlarged heart. Smoker presents with chronic cough of 1 month duration, hemoptysis and swelling of right side of face and of right arm. Which vein is obstructed? Right brachiocephalic, innominate, vein. Causes of obstruction to right brachiocephalic vein. Apical lung tumor. Thrombus due to prolonged presence of central catheter. How is right brachiocephalic formed? By union of right subclavian vein and right internal jugular vein. Where does external jugular vein drain to? Subclavian vein. Which lymphatic duct drains into right brachiocephalic vein? Right lymphatic duct. This drains lymph from right upper limb, right neck, right face, right hemithorax and right upper abdomen. Subclavian vein is a continuation of which vein? Axillary vein. External jugular vein drains which parts? Scalp. Lateral face. Internal jugular veins which parts? Brain. Face. Neck. What is superior vena cava syndrome or SVC syndrome? Syndrome caused by obstruction of SVC. After vaginal delivery, profuse vaginal bleeding is noted. Uterus is boggy. Uterine massage and uterotonic medications fail to stop bleeding. What is the diagnosis? Uterine atony. Postpartum hemorrhage, PPH, can be stopped by bilateral ligation of which arteries? Internal iliac arteries. How does uterine atony cause PPH? By failure of uterus to compress placental sight vessels. Why is bilateral internal iliac artery ligation preferred to bilateral uterine artery ligation in PPH? Because, during pregnancy, there are robust collaterals to uterine artery from other branches of internal iliac artery like vaginal artery. What is uterine artery a branch of? It is a branch of anterior division of internal iliac artery. Another name for internal iliac artery, hypogastric artery. Will bilateral internal iliac artery ligation, in a case of PPH, prevent hysterectomy? Explain. Yes. Due to anastomoses from external iliac artery. Which branch of internal iliac artery runs through the sciatic foramen to supply the perineum? Internal pudendal artery. Ovarian artery arises from which artery? Abdominal aorta. It supplies some part of uterus also, in addition to the ovary. Stroke patient. Weakness of left upper and lower limbs and of left lower face. Preferentially looks to right. When drawing a clock, draws all numbers and hands on right, leaving left side vacant. Which artery is occluded? Right middle cerebral artery. How is gaze deviation in MCA infarction? Affection of which part of brain causes that? Gaze deviation or gaze preference is to same side of lesion. It happens due to affection of frontal eye field. This is seen in prefrontal and premotor cortices. Which lobe affection causes contralateral neglect? Parietal lobe. What is anosognosia? Which cortex affection causes that? Unawareness of one's own condition. Due to lesion in non-dominant parietal cortex, usually right. Which lobes are supplied by the middle cerebral artery? Posterior part of frontal lobe. Anterior part of parietal lobe. Learn to identify parts of circle of Willis in Mr. Angiogram. What behavioral changes can happen in prefrontal lesions? Abulia. Emotional disturbance. Executive dysfunction. Primitive reflex like grasp reflex. Which side MCA occlusion can lead to aphasia? Left MCA occlusion. Occlusion of which artery leads to pontine stroke? Basilar stroke. Occlusion of which cerebral artery leads to contralateral motor or sensory deficits in lower limbs? Anterior cerebral artery. A young woman who is on antipsychotics develops amenorrhea and bilateral milky nipple discharge, galactorrhea. What is the reason? Hyperprolactinemia. Antipsychotics block which dopamine receptor? D2 receptor. Which are the dopaminergic pathways in the brain? Mesolimbic, mesocortical, tuberoinfundibular, nigrostriatal. Dopamine hyperactivity in which of these pathways leads to positive psychotic symptoms like hallucinations and delusions? Mesolimbic pathway. Therapeutic effect of antipsychotics is from D2 blockage of which dopaminergic pathway? Mesolimbic pathway. Hyperprolactinemia occurs with antipsychotics due to blockage of which dopaminergic pathway? Tuberoinfundibular pathway. Tuberoinfundibular pathway arises from which part of the brain and ends in which part of the brain? Arises in arcuate nucleus of hypothalamus and ends in pituitary gland. What is the function of this pathway? Inhibition of prolactin secretion from the pituitary. How is this achieved? Neurons from hypothalamus secrete dopamine which bind to D2 receptors on pituitary lactotrophs, inhibiting them. What is arcuate fasciculus? The pathway which connects Broca area with Wernicke area. What aphasia happens with disruption of arcuate fasciculus? Conduction aphasia. What are the features of conduction aphasia? Impaired repetition, intact comprehension, fluent speech. Hypothalamospinal tract goes from hypothalamus to which part of spinal cord? Ciliospinal center of intermediolateral cell column of T1 to L2. Function of hypothalamospinal tract. Sympathetic innervation to ipsilateral eye and face. What happens if hypothalamospinal tract is disrupted? Ipsilateral Horner syndrome, ptosis, meiosis, anhidrosis. What is the function of lateral medullary spinothalamic tract? Transmits pain and temperature from one half of body to opposite thalamus. What is the condition in which lateral medullary spinothalamic tract is affected? Lateral medullary infarction or Wallenberg syndrome. What are the features of Wallenberg syndrome? Loss of pain and temperature sensation on ipsilateral face and contralateral body. Vertigo, hoarseness, dysphagia, abnormal eye movements. Nigrostriatal pathway is from which part of the brain to which part? From substantia nigra to caudate nucleus and putamen. What is the function of nigrostriatal pathway? Coordination of voluntary movements. Drug-induced Parkinsonism happens due to D2 receptor blockade of which pathway? Nigrostriatal pathway. 2-year-old child has barking cough and dyspnea. Inspiratory stridor and suprasternal intercostal retraction are present. Diagnosis? Croup. Not epiglottitis. In epiglottitis, there will be inspiratory stridor, but patient will be in respiratory distress and barking cough is absent. Child with croup is generally comfortable. Croup is caused by which virus? Parainfluenza virus. Age range of croup? 6 months to 3 years. How does virus reach lower respiratory tract? After initial upper respiratory infection. Which part of lower respiratory tract is affected in croup? Larynx and trachea. Epiglottis is normal. Why is there inspiratory stridor in croup? Due to inflammatory edema of proximal trachea or subglottis. What are the lower respiratory signs in croup? Inspiratory stridor, hoarseness, barking cough. X-ray finding in croup? Steeple sign, subglottic narrowing. Tonsils can be inflamed in which viral infection? IMN. What is the voice in tonsillitis? Hot potato voice. What is Ludwig angina? Rapidly progressive cellulitis of submandibular and sublingual spaces due to infection of mandibular molars. Age group of Ludwig angina. Adults. Clinical features of Ludwig angina. Drooling and tripod positioning. Woody, induration of neck. Firm, elevated floor of mouth. What is the danger in Ludwig angina? Airway obstruction due to posterior displacement of tongue. Epiglottitis is typically seen in which group? Unimmunized children. Clinical features of epiglottitis. Very ill, anxious, respiratory distress, drooling, tripod positioning. High fever. Stridor. Which muscle in the abdomen is important in performing Valsalva maneuver? Rectus. Innervation of gluteus minimus and gluteus medius. Superior gluteal nerve. Innervation of gluteus maximus. Inferior gluteal nerve. Function of gluteus minimus and gluteus medius. Preventing contralateral pelvis from dipping with leg elevation from ground. Function of gluteus maximus. Thigh extension. Young man with painless gross hematuria. During cystoscopy, bleeding is noted from one ureter into the bladder. Diagnosis? Renal papillary necrosis. How to clinically differentiate between hematuria from upper collecting system, above bladder, and lower collecting system. Upper collecting system hematuria throughout urinary stream. Lower collecting system terminal hematuria or initial hematuria. Causes of hematuria throughout urinary stream. Renal mass. Benign, malignant. PCKD. Renal papillary necrosis. Glomerulonephritis. Pyelonephritis. Urolithiasis. Urothelial cancer. Trauma. Causes of terminal hematuria. Urothelial cancer. Cystitis. Infectious or post-radiation. Urolithiasis. Bladder rupture. BPH. Prostate cancer. Causes of initial hematuria. Urethritis. Trauma e.g. catheterization. Corners of trigon of bladder. Urethral orifices. Internal urethral opening. Renal papillary necrosis painless or painful? Painless. Renal papillary necrosis cause? Infarction of renal medullary vessels leads to sloughing of papillae. Renal papillary necrosis level of hematuria? Gross. Renal papillary necrosis causes? Sickle cell nephropathy important cause. Analgesics. Obstructive uropathy. Diabetes mellitus. Renal papillary necrosis course of illness? Self-limiting. Calovesical fistula clinical feature. Stools and air in urine. Calovesical fistula cystoscopy finding. Erythematous, edematous opening in bladder wall. Features of urethral diverticulum. Post-void dribbling. Frequent UTI. Hematuria. After long car drive, obese diabetic has burning sensation and numbness over left upper lateral thigh. On examination, this area is numb. Diagnosis? Meralgia paresthetica. Meralgia paresthetica which nerve? Lateral femoral cutaneous nerve. Lateral femoral cutaneous nerve origin? Directly from lumbar plexus L2 and L3. Lateral femoral cutaneous nerve course? Lateral to PSOS muscle. Beneath inguinal ligament. Meralgia paresthetica causes? Obesity. Tight clothing, seatbelt. Surgery e.g. hip arthroplasty. Increases lumbar lordosis e.g. pregnancy. Diabetes mellitus. Meralgia paresthetica clinical features. Upper lateral thigh. Pain, paresthesia, numbness. Meralgia paresthetica is there weakness? No. Meralgia paresthetica treatment. Weight loss. Avoidance of tight clothing. Ilioinguinal nerve sensory innervation. Upper medial thigh. Genital. Ilioinguinal nerve course. Accompanies spermatic cord through superficial inguinal ring. Ilioinguinal nerve cause of damage. Pelvic or hernia surgery. Ilioinguinal nerve symptoms of damage. Suprapubic and groin pain. Obturator nerve causes of injury. Anterior hip dislocation. Pelvic surgery. Obturator nerve features of damage. Sensory medial thigh. Motor adductor weakness. Pelvic splanchnic nerves sympathetic or parasympathetic. Parasympathetic. Pelvic splanchnic nerves roots. S2-S4. Pelvic splanchnic nerves innervation and function. Hindgut, peristalsis, defecation. Bladder, urinary sphincter, micturition. Pelvic splanchnic nerves cause of damage. Cauda equina syndrome e.g. lumbar epidural metastasis. Sciatic nerve origin. L4-S3. Sciatic nerve sites of compression. Spine level e.g. disc herniation. Piriformis muscle. Greater sciatic foramen. Posterior thigh. Sciatic nerve name for symptoms due to compression. Sciatica. Sciatica clinical features. Back and buttock pain radiating down posterior lower limb to foot. Lower limb weakness. Positive SLR.